Good morning, everybody. For those that are here in person as well as online, we're going to go ahead and get started. But before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And of course, as a reminder, this is National Indigenous Month, and tomorrow is the official National Indigenous History Day. And I know there's a lot of displays and events and things across the city. So hopefully we all get an opportunity to take some of that in to just celebrate our National Indigenous History. Okay, so delighted, last grand rounds of the year, right? To introduce our speaker this morning, Dr. Peter Kannu is an associate professor and the chair of the Department of Medical Genetics at the University of Alberta. He's a clinical geneticist and physician investigator with a longstanding interest in the diagnosis, management, and molecular characterization of skeletal dysplasias and other rare genetic disorders affecting bone and cartilage. Dr. Kannu's research program focuses on understanding the pathobiology of inherited skeletal disorders, with particular emphasis on elucidating disease mechanisms and identifying novel therapeutic approaches. His laboratory employs a combination of genomics and cell-based disease modeling to investigate the molecular underpinnings of rare skeletal conditions. On the clinical side, he runs 4 separate drug trials investigating the use of novel therapies for skeletal dysplasias. In addition to his research and clinical work, Dr. Kannu is actively involved in training the next generation of geneticists and contributes to national and international efforts aimed at improving care for individuals living with rare diseases. So delighted to ask Dr. Kannu to present our grand rounds this morning on the Ehlers Danlos Syndrome disease spectrum.
Thanks, Naman, and good morning to everyone who's woken up bright and early on a Friday to come and listen. I really appreciate that the invitation to talk about the Ehlers Danlos Syndrome. And I realize that some of us here are very advanced practitioners dealing with this patient group, and some of us may be interested just to learn about the whole spectrum. And so it's a mixed audience, and I hope I'm able to cater for both groups of people. So I have to say I'm not going to be actually encouraging any drug therapies or anything to do with any of my advisory board work here. So I have outlined the objectives for the talk, and they're really going to be slightly different. And basically what I want to summarize here is that Ehlers Danlos Syndrome is a group of conditions. They're about, I think they're about 13 or 15 of them. They've got overlapping phenotypes, and that's what makes them so difficult to sort of separate out. And they also have genetic causes that are different. But by and large, you know, about 99% of the referrals that we receive in medical genetics are for the hypermobile type. And so the vascular and classical subtypes, which I'm going to spend some time talking about today, because they overlap with the phenotypes with the hypermobile type, are incredibly rare, but important to recognize because they're medically actionable. So I really base, you know, a lot of my talk on what I've read in the literature, but also I've worked in the area of bone dysplasias for about 20 years. And so I've had the opportunity to see practices with regards to Ehlers Danlos Syndrome in 4 different academic centers as an attending over the year. And what I hope that I can convince the audience here today is the importance of a multidisciplinary team to manage conditions which are very complex, which have a single etiology, but cause a whole spectrum of diseases that no one physician can manage by themselves. So this is the Ehlers Danlos Syndrome group of conditions. And so they're heritable and they're generally collagen-based conditions. The best estimate is that they're about 1 in 5,000. And so to put that in perspective, all of us here probably know about neurofibromatosis type 1, and that's a 1 in 3,000 disorder. So Ehlers Danlos is roughly in that ballpark as well. There are quite a few people. There are 14 subtypes and 19 different genes that are involved in the collagen and the extracellular matrix synthesis and maintenance. And as I've said, they affect a myriad of body systems. And the hypomobile type is by far the most common and the most abundant group. So what exactly is collagen? So collagen is a rope-like structure, and it essentially is something that is twined, and there are generally 3 different twines that make this really strong rope. And the interesting thing about collagen is it doesn't start winding from the left-hand side, but in fact it starts in reverse. It starts winding from the other side, which is over here. And so you can imagine that sometimes if you've got a mutation over here, it's going to be much more catastrophic because the folding is not going to be able to occur properly. So collagens there's about 27 different types of collagen. And the way I remember it is the skin collagen is type 1 collagen. So skin collagen, bone collagen, teeth collagen is type 1. And that's why you get things like osteogenesis imperfecta or brittle bone. Type 2 collagen, on the other hand, is the cartilage collagen. And that's the one that causes premature osteoarthritis in people that present for joint replacements in their late 30s or 40s. The other collagen is type 3 collagen, which is generally the vascular collagen, which we'll touch on today as well. So the phenotypes that I want to discuss today are, in addition to the hypermobile type of Ehlers-Danlos, I want to spend some time talking about the classical phenotype and the vascular phenotype. The classical phenotype is caused by mutations in collagen 5. And again, it's an autosomal dominant condition, meaning there's male-to-male transmission, and an affected individual has a 50% chance of passing it on. There's also a classical-like phenotype due to tenexin XB that was more recently described. And then there's a recessive form of Ehlers-Danlos, which causes a vascular type phenotype, but much more with a cardiac complication. And I've put here the different type of features that you see in these different Ehlers-Danlos syndromes, but you will notice things like easy bruising kind of appear in most of them. And so one can argue that that may not be a sensitive enough discriminating factor to distinguish between the different types. And one needs to look at the different aspects of the phenotype to make the diagnosis. So by and large, all these Ehlers-Danlos syndromes, which were originally described and put together by a colleague in Seattle, Dr. Peter Byers, are based on hypermobility. And hypermobility, can affect all joints in our body. So people have temporomandibular subluxations. Some people describe to me their ribs push out when they sneeze. But unfortunately, when you're scoring it, according to the Beighton score, these joints are not taken into account. The joints that are the fifth finger, the wrist, the elbows, the knees, and then finally the back with extension. So you can imagine you can have hypermobility in other joints, but they're just not assessed by the Beighton score. Just want to point out the limitations in the scoring system. We use a score of more than 4 to suggest that one is hypomobile, and we also take into account that someone who is 50 years old may have been much more flexible when they're 20. And similarly, a child, under 10 is very flexible. And so I find it very hard to suggest that they have hypomobility. You just don't know where they're going to end up as they get older. So looking at the 3 different forms or subtypes of Ehlers-Danlos that I'd like to concentrate on, I want to draw your attention to the fact that the hypermobile type generally presents with hypomobility. And another distinguishing feature is the pain in this condition is incredibly difficult to manage. It's considered to be sometimes by some folks worse than the pain in rheumatoid arthritis. The classical form is very much a skin phenotype, and these folks present with terrible, terrible skin, generally not much pain. I still remember distinctly about 15 years ago seeing this chap that had these scars all over his hands. He was a boxer. His skin was terrible, never came to attention simply because there was no pain. The vascular Ehlers-Danlos syndrome, I have to say, the most referrals we get is from the coroner. And they're identified when someone sadly passes away because the condition was simply not recognized while they were alive. And so once again, pain is a feature, but it is not the overriding feature in this particular condition. So moving on first to talk about the vascular Ehlers-Danlos syndrome, which is the rarest of the three phenotypes that I'm going to discuss. And it has about, I said to you, Ehlers-Danlos is 1 in 5,000, and so this is 1 in 50,000. So it's similar to the patients I see with achondroplasia. We might be getting 1 or 2 born every year, right? So it's incredibly rare, 8% of all the cohort, and it's due to the vascular collagen, which is type 3 collagen. Now, one of the characteristics features is the thin and translucent skin. So the skin really looks very papery, and oftentimes over the knees you get these sort of iron staining from the bleeds or the bruising that people have had progressively over time. The emergencies tend to involve bleeding, large vessels, in particular in the thorax and the abdomen. And generally, folks have presented by the 4th decade of life, right? They've had some sort of catastrophe in their life. So if you think about it, someone who's presenting later on, who has not experienced any of these things, but comes in with hypermobility and pain, is less likely to have the vascular form of this condition. So how do you make the diagnosis? So the diagnosis, it rests in genetic testing, but like with any things, we do try and ration testing. And so we try and figure out, well, what are the criteria that one needs to have to be able to be pushed into the category of, yes, this person should be tested. As I said, positive family history, the coroners generally contact us or write us a letter if a pathogenic variant has been identified in a COL3 case, and we see the family members. Any person who's had some sort of arterial rupture or dissection or hollow organ perforation, the sigmoid colon, uterine prolapse, rupture, these things signal to me this is more than the hypermobile type of Ehlers-Danlos syndrome and unusual sort of blood vessel connections. Now, they're also the minor criteria. And, one of my mentors once said to me, a single swallow does a summer not make. And I think that's really a tenet in medicine. We don't just look at one feature and say, aha, this is the discriminating feature. It needs to be the package that builds our sort of clinical suspicion that someone has something. So it's not any one of these features that is going to make me think, vascular Ehlers-Danlos syndrome. Although if someone comes in with a pneumothorax, in addition to looking for MAFN, I always check for vascular. The facies is characteristic, but it can be difficult to identify. They talk about a thin lip, they talk about a thin nose, and they talk about big eyes simply because of the subcutaneous tissue lacking, right? But it's a subtle feature, and so I don't think we should place too much weight on face gazing as we do in genetics. We've moved on from that as a specialty. Keratoconus, it could be also a feature of Ehlers-Danlos vascular type, though a lot of people have keratoconus and we simply don't know what it's due to. So the other features are, of course, the easy bruising, the premature aging of the hand. So the skin looks kind of, looks like an old person's hands, the facial appearance that I've been telling about. In kids, when they present with congenital dislocation of the hips, generally bilateral or talipes, these are sort of red flags to us that, they may be a collagen condition of some sort. And obviously unexplained organ tissue fragility, right, during surgery or post-operatively. And I sometimes get referrals from particularly the obstetricians about this because they say, this person is being incredibly difficult to fix. Nothing I do keeps everything together. And so, that's a red flag for me. So Uh, 75%, as I said, have already experienced their first major complication by 40 years. And the people that are referred come because of a family history of sudden death, excessive bruising, the translucent skin, or the acrogeria, which is the premature aging that you see in the hands, right? The face is much more difficult, I think, to recognize unless you look after a whole stack of people with this. So, because vascular EDS is so rare, we do have, I have one particular large family here, and we're identifying so many different people that are asymptomatic. And I understand Dr. Ritchie looks after several people, families in the clinic, but this is a rare condition. And so one needs to go to the evidence to see, well, what do these folks present with? And you can see the myriad of factors, right? The vascular events here, the dissections, dissections of smaller arteries as well, the pneumothorax that I've talked about, and then the hollow organ ruptures. So that kind of, and I think most of us would say if anyone young comes in with one of these things, this is weird, and we need to think about what could be behind the presentation. So that's giving you an idea of what it is, and spending more time on the hollow organ ruptures, right? So we know that colonic perforations are just uncommon in the population. And if they do occur, it occurs in the context of someone who has diverticulitis. But bowel rupture occurs in about 25% of this group, right? So in addition to the artery rupture, think about hollow organ ruptures. And the colonic perforations can start quite early in life, right? Oftentimes they've just not been recognized as this is a feature of a connective tissue disorder and referred for testing and diagnosis. As I said, they mainly get referred if there's a history of sudden death. Now, pregnancy is also a particularly vulnerable time for these folks. 31% have some sort of complication, prolonged bleeding, that sort of things, life-threatening complications. We've talked about the uterine rupture, the tears that these people get. Neurological and intracranial complications, interestingly, are much rarer in this folk. And so when I think about intracranial aneurysms, I do test for vascular EDS, but I'm thinking much more of other causes of genetic causes of aneurysms in this particular cohort that I see. I mentioned, always think in addition to Marfan syndrome, when you have a young guy or girl coming in with a pneumothorax, that they may have vascular EDS. We always check for this, we check for Birt-Hogg-Dubé, which causes pneumothorax. We check for Marfan syndrome, and we check for vascular all at once when these referrals come in. So what is the differential diagnosis? And I think by and large, genetics has grown much more from a birth defects registry that it was 50 years ago. And 2/3 of our patients that we see in genetics tend to be adults, and half of them are cancer and half of them come to me because I do the connective tissue disorders, and we often get referrals from Doctors Vandermeul and Sean McMurtry for folks that are young who have unexplained aortic dilatation or dissections. And you think about vascular EDS in this context, but you also think about conditions such as Marfan syndrome, and you think about an associate condition called Louis-Dietz syndrome. So these are Marfan-like syndromes due to other genes. I would just encourage everyone, if you are thinking about Marfan syndrome, please do consider scoring them on the Gantt score. The absence of a lens dislocation and the absence of a cardiac complication does influence my decision when I'm seeing the patient in terms of trying to triage how urgently they need to be seen. Then there are also these lax skin conditions, which we kind of put into the cutis laxa syndrome, which can have cardiac presentations as well. So what do you do for these folks if you do see them? And I think the biggest concern you have is that they're going to rupture. and generally they're going to need some sort of screening. We try and avoid an arteriography because, you know, the blood vessels are very fragile and you don't want to provoke someone into rupturing. And so you want to do something non-invasive. I can't speak less of how much blood pressure monitoring, just a simple blood pressure can do, because if you do have hypertension, you want to get in and treat that urgently. The Sheffield study a few years ago showed that these folks generally responded to an angiotensin 2 blocker or a beta blocker. And I think Dr. Ritchie uses a beta blocker in his clinic. You also want to avoid things like routine colonoscopy, once again, because you might perforate the organs. And elective surgery in these people can be dangerous. And so one says that you really need to have something done, right? Obviously, it's a risk-benefit situation here. So moving on now to the classical type of Ehlers Danlos syndrome, which I said to you is the skin type. And generally one recognizes this condition because the skin is really flexible. So in hypermobile type, it is flexible, but it's not to the degree that you see in the classical form. So if you're one that wants to be very objective with your criteria, we use a 3 centimeter rule. So in other words, you can pull your skin out for 3 centimeters or 1.5 around the elbows. That meets the criteria. I know in the Toronto EDS clinic, they get their calipers out and they actually manage it. So it's a question of whether you're a very objective type of physician or you want to take a more like, you know, does this make sense appearance. But look at these terrible scars that these people have, right? Anyone would say, yes, something's wrong with you. This is not normal. And they may have joint hypermobility, but it generally tends to be of the hands, and it generally does not cause as much pain as the hypermobile type does. So the incidence of the classical form is 1 in 20,000. I said vascular was about 1 in 50,000. So look at all these scars, right? Sometimes we describe these as cigarette paper-like. They're particularly over the knees because most of us sort of get, you know, childhood accidents, either biking or running. And as we age, these scars just don't simply heal properly. I also asked to examine the surgical scars, look for really proud keloid type scars. In addition, but these are terrible scars, right? And so these folks really need to be stitched out by the best person in the room if they do end up in emergency. And so if you look at the data once again on classical EDS, because this is so rare, and I don't think we can all really depend on our individual clinical experiences because none of us see that many folks unless you run a very large clinic. So when they did look at a patient group in this particular study here, they found that 78% met the combined criteria of skin hyperextensibility and scoring, right? So not everyone did. And as I've mentioned, joint hypermobility tends to decline with age, and you need to factor that in when you're assessing an older person. So in addition to the scars, these folks had joint hypermobility, but they also had things like flat feet. They had dislocations, right? So that could be confused with the hypermobile type. Mitral valve prolapse and arterial features were noted, but generally these people do not go on to develop complications associated with it. So I think that's the value of telling someone you have classical as opposed to vascular, because I think you'd probably still monitor them, but you're not as concerned that they're going to run into problems with a rupture. They get bleeding. They get the GI symptoms as well, gastroesophageal reflux. The gut doesn't move as well as properly. They get motility problems, and that's just because collagen is all in your connective tissue. And they can get the other sort of dysautonomic features that you find in hypermobile, headaches, fatigue, etc., etc. So looking at the prevalence of these features across a cohort, I just want you to notice that that if you look over here, right, neuropathic pain didn't occur in a lot of people. In fact, the pain that they got was mainly headaches and migraines. They complained of fatigue and clumsiness. If you looked at the hypermobile cohort, the pain would be right up there. We've talked about the classical features, the mitral valve prolapse, which, as I said, generally doesn't cause problems. Look at the fibromyalgia pain as well in this cohort. It's very low compared to sort of non-specific cramps that they get. GI symptoms are quite feature quite highly the bleeding problems that you see in the gynae world, and they seem to also have an issue with allergies, which is also seen in the hypermobile group. So one thing to remember, that collagen also is important in your airways. And so these individuals, in addition to cough, which could either be, respiratory or GI in nature, also can have a tendency to airway collapse, increase lung compliance as well, and so breathing problems. And so I just wanted to point out here that the pain relief that these people used was generally Tylenol or non-steroidal anti-inflammatories, and they didn't seem to need things that were stronger that we see in the hypermobile group. So the management decisions, as I said, get the best person in the room to do the stitching because it is notoriously the wound healing is poor. I happen to be trained by the person who trained me initially in genetics was a dermatologist who was a geneticist as well, and so she provided a lot. She had a lot of experience in the classical form of EDS and the skin complications. Just remember that these people do get GI complications, and just remember, like anything, exercise is one of the best things one can do. And I always tell my patients, I'm not asking you to go weight training or go into aerobics class. I'm asking you to do light weights as you can, and not to injure yourself, but to keep mobile because it builds your bones. It's important for your stability, as well as your general well-being. Now, some people do recommend ascorbic acid. I think it's a harmless medication, so take it if it works. Desmopressin may also be used in the surgical situation. And what do you need to do? Obviously, you need to avoid trauma, right? So if you see someone that is young with classical EDS, if they're thinking about an occupation where they want to be a skydiver or something like that, it's probably not the best thing for them to be on. And obviously, the cardiac monitoring continues, even though it's going to be a more benign cause. So now we're going to move on to the most challenging group, I think, of Ehlers Danlos syndrome. And in genetics, we get roughly over 200 referrals for this. And we've like all the other genetic centers in Canada, we've stopped taking these referrals because there's no genetic testing available for this condition. It remains an enigma. We don't know whether we're dealing with a cluster of endophenotypes with different genes, and people are presenting with sort of a combined constellation, or if there's some missing gene that, despite all the best sequencing, we're just not being able to put our finger on. Now, these folks are challenging for many, many different reasons because they generally come because of the pain, and the pain is quite debilitating. And I've seen this in the younger people, 17, 18, 19, who are not able to go to school. They're checking out of life. And I feel that this is not a good situation because if you don't finish school, you end up not having a career and you lag further and further behind your cohort as the cohort goes on. Now, in addition to the hypermobility, to make the diagnosis of hypermobile EDS, you need the extra joint symptoms as well. And you need at least 5 out of 12 of these extra joint symptoms, right? Most physicians I see seem concerned that they are not comfortable making the diagnosis. They feel that they may be overdiagnosing, or some may feel they are underdiagnosing. And I think, the profession hasn't done favors to this condition. We've changed the criteria quite a few times. And sometimes the criteria are also quite subjective, like the skin. And you talk about, is your skin soft, is your skin flexible? Well, all of us in the room might have a different opinion on that. So I think that's some of the reasons that the problems with the diagnosis and why they arise. But if you look at these the reasons that these people present, and you see once again it's a very multifactorial issue, right? They complain about coordination issues. I was just talking with one of the physicians earlier about her patient that comes in with a wheelchair, the gastrointestinal problems. So this is talking about, in addition to reflux, they get irritable bowel type symptoms as well. The dysautonomia, which presents with conditions such as postural hypotension, the mitral valve prolapse, mild aortic dilatation. And again, in these individuals, it seems non-progressive and does not require intervention. Now, there seems to be also an association with these other neurodevelopmental disorders. One can argue that all these other conditions, such as ADHD and autism, are common in the population. So how do we know they're just not coexisting together? Like, what is the biological basis of this, right? But these are the questions that generally people say, I've got autism. Is it linked to HEDS? Or I've got ADHD, right? And what is important to note that the levels of anxiety and depression are very high in this group, and oftentimes they're untreated. They don't have a mental health professional that's involved. So if you look at this group of individuals presenting with joint hypermobility, and joint hypermobility by itself is a diagnosis. And then Ehlers Danlos syndrome with joint hypermobility is another diagnosis. And so when you have Ehlers Danlos syndrome, you need to have, as I said, these extra joint manifestations as well. What are these extra joint manifestations? Well, the hyperextensible skin, the skin texture, the atrophic scars that I mentioned before. So you need to have two or more. Then you can have things like organ prolapses as well. So inguinal hernias, uterine prolapse, that sort of thing. Then obviously the cardiovascular problems that you get. In addition to varicose veins, Raynaud's phenomena, all these associated features as well. And then finally, when you're trying to figure out, well, is this, joint hypermobility? Is this Ehlers-Danlos syndrome, hypermobile type? That's when you think about all these other very rare and unique conditions that geneticists see, such as Marfan syndrome, Louis-Dietz syndrome, osteogenesis imperfecta, right? And that's where the differential diagnosis comes in. So the autonomic and sensory dysfunction is described by many individuals, but it's not part of the diagnostic criteria. And they seem to have an exaggerated vascular response. And so oftentimes they describe the fact that when they stand up, they feel they're going to have a syncopal episode. The lights go off, they see stars, that sort of thing. And most of them are, already trying to hydrate themselves as best as possible. And they're concerned that this is not enough. And so we do have, I recommend a simple thing to see whether you have any objective evidence of it is a series of 3 heart rates and blood pressure monitoring that can be done by anyone, sitting and then standing, right? And if there's evidence that there is a disconnect there with your heart rate and your blood pressure, then it's maybe, if you wanted to, a referral for tilt table testing. There is an autonomic function lab in Calgary for the patients with EDS. They're very strict with the criteria. You need to have your 3 blood pressure and heart rate monitorings done in a clinic to demonstrate the need for them to accept the referral there. And then in terms of the treatment, right, that's kind of quite variable. So some people describe needing intravenous saline. And they say that helps really well. I know Dr. Lawrence Richer, one of the pediatric neurologists, has told me that he has given them immunoglobulin infusions, which I was intrigued by. And in my reading, I understand that some folks believe that there is an autoimmune basis. So I don't know. A lot of these studies, are not sort of done with the rigor that one would need to say that there is clear evidence for this or for that. So people are using all these types of treatments. And I believe the cardiologist may also prescribe fluid tablets, fluid retaining tablets to help them. But that's really outside my scope. So just to make the point, at one end that we have the Ehlers Danlos syndrome with joint hypermobility, but joint hypermobility by itself can be a diagnosis. And it used to be called benign joint hypermobility, and the benign has now been removed to recognize that people can be quite disabled by the hypermobility itself, right? And what I want you to know, to take home, is that when we talk about the spectrum of disorders, we're not talking about a linear spectrum, right? It's not, you either have mild, moderate, and severe. It really means that a person can have hypermobility in any one of these features. And this is what we recognize in clinical practice, that sometimes individuals do not make the diagnosis for hypermobile EDS, but they do have hypermobility. They do have some of the features. And I think in that situation, it is important for them to be validated that they do have a condition on a medical spectrum. We don't know what causes it, and we're not terribly good at treating it either. I guess in genetics, where we hardly treat anyone, we do find validating someone's condition seems to be beneficial for them. So thinking about the dislocations that occur in EDS, and I put this out here because there are genetic conditions which cause dislocations as well. And the way I recognize them is that these people generally have deformed joints because of the chronic dislocations. You do not typically see this in HEDS. And so when you're looking at the large studies, they found that the hypermobile patients have similar outcomes when undergoing procedures for the hips, knees, shoulders, and elbows, but much, much worse outcomes with the ankle, which is a weight-bearing joint and is difficult to fit. One of the reasons that that folks are referred is because the orthopedic surgeons are concerned that when they go in to do a surgical procedure, the patient may not heal properly. And so they want some reassurance from me that there is a diagnosis, because I think they counsel differently in terms of their preoperative management. Now, the pain, as I said, is a predominant feature in Ehlers-Danlos syndrome. I think the pain mechanisms are really complex, right? I think, what I've not said here is that we never, ask about generational trauma or early childhood trauma in these patients to figure out whether that could be some sort of factor that predisposes certain individuals to experience much, much more pain as an adult than as normal. The treatments that we try, are a myriad. Obviously, we start off with the non-steroidal anti-inflammatories, which can be bad for your gut. We think about things like the gabapentin or the neuromodulating treatments as well. Some people find nerve blocks helpful. Some people find injections of the ligaments helpful that are given by the physiatrist. But everyone seems to be different in terms of their response, right? And I think what we don't have is a sort of a team here to be able to look after these people, because it is draining when your patient is telling you all these things and you feel as a physician quite powerless, and you're worried, am I missing something? Or am I doing the very best? And I think a team-based approach allows one to share the responsibility, because you sit down and you discuss each patient afterwards, and people come to a consensus decision, and you feel, well, I'm not mad in what I'm saying, right? Because my team members agree with me. And I think it's a really important part of medicine when you're dealing with complex patients who have multifactorial needs. And so that's my plug for, can we have a multi-D clinic of some sort here in Edmonton? I was very interested to find that, the American Gastroenterology Society has actually come up for some guidelines with the GI management. And I think because they see a lot of folks who have irritable bowel, the gastric dysmotility, constipation, the gastroesophageal reflux. And so they have suggested that, gastroenterologists consider applying the diagnostic criteria, which is a clinical set of criteria when they are dealing with these folks. And they talk about, the gut-brain interface here. One of the other complaints that HEDS folks present with, and it's again not part of the diagnostic criteria, is this mast cell activation syndrome. And so individuals report in terms of when they're anxious, when they're upset, perhaps with a hot shower, they just break out with these rashes that are really itchy, and then the rashes go. And it's because of the mast cells releasing histamine. And obviously this can cause headaches and gut pain as well. Now, simple over-the-counter measures, according to the allergist, is to start yourself on one of the over-the-counter antihistamines, which are non-sedating. If you're looking for a much more formal diagnosis, and I understand from my allergy colleagues, they never seem to find objective evidence. That's what they've told me. You need to measure the tryptase level, and you need to do one when the patient is, without rashes, and obviously they're going to need a requisition for one when their rashes occur, because you never know when the rashes are going to go away. But to the best of my knowledge, the treatment is, the mainstay is an antihistamine. And so, one can argue, do you go just by, you've got a symptom, like in a lot of things in medicine, and prescribe, or do you seek the objective evidence? So interestingly, the gastroenterologists talk about testing for mast cell activation syndrome in patients who present with, visceral somatic pain, pruritus, all the features that you would associate with histamine release. One of the other complications that you get in HEDS, so I've had patients that find they can't talk properly, or their voice quality has been affected. And the ENT studies suggest this could be due to discoordination or hypertonia of the vocal cords, sleep apnea in this patient as well, because pharyngeal collapsibility or cartilage defects, and also respiratory muscle defects. So they can get a host of respiratory symptoms as well. Now, the group, as I said, the group in Calgary has an Ehlers Danlos Syndrome clinic. I think it's run by a physiatrist or a rehabilitation doctor. But this was a study that was done by their allied health professionals, a prospective study between 2019 and 2024. And this was basically a self-report of demographic data. And what they found was depression was highly prevalent. There was a strong association between pain, catastrophizing, and fatigue. I have had a patient who's asked for MAID in this situation with hypermobile EDS, and it was granted by the province. So, there's a lot of stuff going on here that no one individual, I think, is equipped to heal, to treat, because for the psychiatric management, I think one can't only rely on a psychiatrist who's doing prescribing. We would need a psychologist, a social worker involved as well. I think it goes a long way in trying to provide education to these people that, this is part of your chronic disease spectrum, because for some people that can be quite empowering. I'm not saying for everyone. But I just wanted to point out the difficulties with managing this group of people because of the high needs. And so with that, I'm happy to end and take questions from the learned audience.
Thanks, Peter. That was fantastic. I'm just going to kick it off, actually, if that's okay. I know Wendy has a burning question, but I wondered, it just seems so certain types of phenotypes there, with you mentioned, doesn't really have a genetic sort of, or at least a biochemical association. At what stage do you tend to see these patients? I mean, you're probably the most, experienced in the room anyways. Do they ever present in childhood, or are the vast majority sort of adults?
Um, no, they do present in childhood. So at Sick Kids, I would see them exclusively in childhood, and these are the ones that they come in a wheelchair, they walk funny, they're not able to go to school. They say they've got brain fog, they've got lethargy, they feel dizzy all the time, and you feel so powerless in terms of what's going on. And what I'm so concerned about is I see someone checking out of life and then never being able to get back into it. So we do see them there. Now, you also see very resilient people with HEDS that have just carried on with their life despite the pain and everything else. So I didn't talk about that today, obviously, but there is that side of the spectrum as well. We don't know why there is a sex difference in presentation. We simply don't understand what's going on there. I, you know, I generally have not seen people with really bad EDS before puberty. It does, they're much older when they present. So the younger children generally are brought to the clinic because their parents think that they're mobile, hypermobile, but generally they're in gymnastics and things like that anyway, right?
The good hypermobility. Wendy.
So I'm gonna ask a very neurologic question, particularly for vascular EDS. The prevalence of migraine at 40% in one of your slides is higher than the general population. And so as a neurologist, do you think that there's a risk with any of the medications, particularly the triptans, which are vascular medications? And for example, we have to be cautious in those with cardiac disease. Although the studies kind of poo-poo that, but in general, the recommendation is to be cautious in those who have ischemic cardiac disease. So with particularly vascular EDS, would you steer away from those vascularly active medications?
Could you hear it? Yes. Okay.
Yeah, so the question is that the tissue fragility in vascular EDS and whether the medications can actually complicate and cause iatrogenic harm. So I have to confess, Wendy, I have very little experience in that, because if they do have headaches, we're kind of blessed here in Edmonton with a few specialists in the community that would look after. So I don't tend to follow up what happens with them. But I do take your point that they could predispose. Though saying that, the vascular events in generally seem to be large arteries, and as I said, around here rather than there. When they do get vascular bleeds from a fragility condition, I'm generally thinking of other types of conditions. So that's my answer, which I don't really, I can't explain it, I think. I don't know whether Dr. Tapperdale would have any further advice. She sees a lot of the EDS patients as well, thankfully.
For now, I think we discussed it a bit. What I wanted to comment is that there is a lot of momentum right now for after the pandemic with long COVID research and some of the overlapping. So we are seeing a significant number of referrals with people who finally found a reason for their chronic pain, for their chronic dizziness. So we get few referrals every week. I just mentioned earlier, we have patients coming with peak life. They ask us to offer fluids every day. We have people coming with wheelchairs and so. And I agree that we need a team because it's becoming very complex, and there is a lot of social media component in this, like people are coming and they're asking us to order particular tests because this is what they've heard on their Facebook group, on their support groups, and not to mention TikTok and some other stuff. But it's certainly a different approach to medicine that I've noticed.
I want to say that some of these folks do have presentations similar to some sort of post-viral condition, right? And we've recognized that much more after COVID. And so one doesn't know whether it's the HEDS that is causing it or whether it's something else that has made them, suddenly decompensate. So, and I'm not, I don't think any one person is clever enough to be able to come to that conclusion. We do need a team for that, to look at the person from a different aspect and come together and provide. That would be a good way of providing a service for them. The other thing is that the community is very empowered, and it's because patient groups are amazing. Really a big fan of them, and the HEDS patient group is very, very active, very proactive. So they've done amazing things like making the guidelines publicly downloadable, making it easy for someone to get a diagnosis. But at the other time, our patients also now come to us with, I think I have this, I think I have that, I think I have that. And so you're in a kind of a defensive mode, trying to say, well, there's no evidence for it. So that's a tricky place to be as well.
I saw a hand here. There is a question online that I'm not sure I understand. Maybe you'll understand it a little bit better. Asking about chondromalacia, if it's DD for HEDS.
So yeah, so that's for HEDS, the bone phenotype. Now, the only way that these folks can get into problems with their bones is with prolonged immobility itself. I am not aware of any other sort of bone changes associated with HEDS per se, and we don't screen them for this particular condition. So that might have been from one of the rheumatologists who asked the question.
It was anonymous. So,
Right. Okay.
yeah.
I hope I've answered that person's question, but otherwise, please come back. I think, the other thing to say is that one of the reasons that individuals are very proactive in trying to find a diagnosis is that these folks have either not able to work and don't have any disability left. And so their last resort is to get AISH. And so that's why the diagnosis is important for them as well. And one is sympathetic to that, right? They've got nothing else. But I would hope that we can provide them with a more comprehensive support service than just dealing with that, if that's possible. I think we've identified, we have a physiotherapist in town that has got an interest in this condition. I heard just recently one of the gastro colleagues is interested. So the expertise is there. It is just bringing it together. And Dr. Ritchie runs a vascular clinic for the EDS patients. So there is the expertise around. It's just that we don't talk to each other regularly.
Yeah, well, and you've hit it on the nail, right? Having a multidisciplinary clinic that brings all of this expertise together, right? It sounds like there needs to be an application for something to support them.
And if we could find a primary care practitioner or two that would also be to vest interest in this, I think it doesn't need to be done by a specialist.
Yeah.
Someone driving the bus can be a generalist and may actually be better than someone that is focused in thing. If there are no other questions, I also want to put out a plug. I have to say, genetics doesn't do terribly much with internal medicine. And I know we don't get your trainees, and we would be so delighted to have people rotating through us. If any of your trainees want, we are actively, I'm so focused that genetics has grown out of pediatrics. It is not a birth defects registry. The number of children with genetic conditions is remaining the same. If we're looking at the market, it is with adults. And most of us are pediatric trained. And so we need people with internal medicine experience who are willing to do another 2 years of a fellowship and go out there and take the population on. Adult genetics is very different from pediatric genetics. Pediatric geneticists, we tend to, say, oh, look at that nose and look at those ears, right? Adult geneticists do not spend time on dysmorphology because most of their patients are not dysmorphic. right? The ones that rupture their aneurysms in their heart, they've got nothing. You can't see anything with them. So it's very much more inclined as a medical specialty. You see the patient, you just figure out what they need testing for, and then you test them, and then you provide the management. So we are actively looking for that. We can train people in Edmonton through the fellowship if there are any trainees that are interested.
We of course used to have Donna Gilchrist, right?
Yeah.
You would know who was the perfect mix of that internal medicine genetics, but we unfortunately haven't been fortunate.
Yeah, I did ask if she wanted to come back, and she said no.
There is one other question, if since we have time. Dr. Romney has a young patient with EDS with refractory dependent edema. I didn't notice that on any of the classical symptoms or signs, edema was something that showed up.
No, and I'm not familiar with that. What type of EDS was that? That he did.
Jacques, you can type in the chat if you want.
No, I'm not aware of. I've not seen anyone with edema.
All right. Oh, Anna, sorry.
Hey, I often feel confused with the hereditary EDS patients without genetic, association in terms of how are they different than just a more bendy fibromyalgia patient?
And a lot of them do come in with the fibromyalgia diagnosis as well. And so what I carefully go through are the 12 extra joint features. And so this includes the positive wrist and thumb sign, the dental crowding, skin, which is either stretchy or flexible, atrophic keloid scars, 2 or more, organ prolapse, multiple, or hernias. I'm not sure if I'm missing any of the other features. So I put them in strictly there. And then they need to have evidence of either subluxations or dislocations causing chronic pain. But there is overlap, right?
Dr. Romney is not sure the type of Ehlers Danlos, but he will connect care message you.
Yeah, thank
your
you.
opinion.
Yeah, so that's a really good question. And I'm not familiar with the diagnosis. How you make the diagnosis of fibromyalgia. It's been some time since I've actually spent time on it, but so I'm not surprised.
Peter, I'm just curious, is this a stock photo or is this something specific? It's a beautiful picture.
No, this was on the Camino. We did this in April.
It's lovely.
Yeah,
Well,
the
thank you.
Portuguese
Thank you for sharing
Camino.
all of those beautiful
Yeah.
pictures, actually. So with that, I will just wish everybody a wonderful summer, and we will, I guess, come back in September, hopefully still in Classroom D. And on behalf of the Department of Medicine, thank you, Peter. That was very enlightening. It sort of helped to put a lot of the types of patients we see together, and hopefully makes us a little bit smarter.
Yeah, thank you. Thank you.
All right,
Thank you.
I'm going to exit.